my voice is clear?
Yes. Okay,
Oh,
go ahead.
okay, my topic of today presentation is blood transfusion management. These are all objectives of my presentation. I will cover all these objectives in coming slides in detail. So what is the definition of blood transfusion? Blood transfusion basically is the IV administration of whole blood or its components such as plasma, packed red cells, or platelets to correct or treat any clinical condition of a patient. Next, are components of blood. There are components of blood: whole blood, packed red cells, fresh frozen plasma, platelets, and cryoprecipitate. Whole blood is further divided into RCCs, granulocyte plasma, then divided into fresh frozen plasma, fractionated product, and then from fresh frozen plasma, cryoprecipitate and cryosupernatant plasma is prepared. And from fractionated product, factor 8, factor 9, factor 7, albumin, etc. are performed. I briefly discuss about these components. The volume of RCC is about 250 to 300 ml, and 1 unit of RCC can increase HB by 1 gram per DL, and the storage of RCC is plus 2 degrees C and plus 6 degrees C in blood bank or in a refrigerator. And the volume of FFPs is about 150 to 200 ml, and the storage of FFP is minus 30 degrees C for 1 year or minus 80 degrees C for 7 years. And the volume of random donor platelets is about 50 to 60 ml, and the storage of platelets is about 20 to minus 24 degrees C in platelets agitator, and single donor platelets volume is about 200 to 250 ml, and the storage of single donor platelets is same that of random donor platelets. These are indication of blood components. RCC replacement of red blood cells in symptomatic anemic patient, also in hemorrhagic patient in severe loss of blood, and FFPs are indicated in the replacement of single coagulation factor deficiency and also in emergency condition, and immediate reversal of warfarin effect, and also in acute DIC. And random donor platelets are used in thrombocytopenia, platelets function defects, prophylactic use in thrombocytopenic patient, and maintain platelets count more than 10,000 in non-bleeding patient and non-infected patient, and maintain platelets count more than 20,000 in infected or pyroxal patient. Also used in acute DIC and prevention of thrombocytopenia in post-BMT patient. And the uses of single donor platelets same as of random donor platelets. So moving on to the next slide, that is blood grouping and cross matching. As you know all that each person has one of the following blood types: A, B, AB or O. O can be given to anyone but can only receive O. AB can receive any type but can only be given to AB. And same like every person has RH factor, which is RH positive, RH or RH negative. This chart shows that blood group A has anti-A antigen in blood cells and anti-B antibodies in plasma. And where in the case of blood group B, blood group B has B antigen in blood cells and anti-A antibody in plasma. Whereas the blood group AB has anti-A and anti-B antigen in blood cells, but has no antibodies in plasma. And blood group O has no antigen in red blood cells, but has anti-A and anti-B antibodies in plasma. Next slide shows the RH positive and RH negative factor. AB blood group is called universal recipient, and O blood group is called universal donor. And same as Rh positive blood group can give to blood received from blood Rh positive and Rh negative person, but Rh negative person only receive from Rh negative person. So the next slide is general instruction for transfusion. When send the blood sample of recipient to blood bank, it should be clearly labeled blood grouping and cross-matching labeling, and with IP number, BMT number, ward number, identification, etc. And blood sample taken within 4 hours for labeling for blood grouping and cross-matching. Request form should be labeled correctly according to the requirement, whole blood or component requirement, and nurse and physician should verify all information on the report of the cross match until label and the patient identification and also the expiry of the blood product. In case of discrepancies, the unit should be returned to the blood bank with remarks, and blood should be transfused through an appropriate sterilized transfusion set containing a filter without any air. And blood unit must be discarded if it has been out of refrigerator for longer than 30 minutes, or this seal is broken, or there is any sign of hemolysis, clotting, or contamination, discoloration. This is the transfusion request form which we send to blood bank, and when we send the sample of recipient to blood bank, we fill this transfusion form according to the requirement, and we also, if we need the irradiated product, then we fill the irradiated column, and also patient hospital number, ward number, bed number, names, age, sex, etc., and also the patient of the blood group of the patient. Special consideration in BMT unit. As you know, that blood product irradiation. All blood products except for harvested marrow will be irradiated prior to infusion, and dose of gamma irradiation should be 25 gamma rays. This dosage doesn't cause clinically relevant damage to RBCs units, which can be stored for at least 28 days. This is the form which we received from blood bank along with the blood bag. And before administration of blood to the recipient, we verify all these information in this form with blood bag. And we also check the stamp of irradiation, because all irradiated blood components we are received from AFIT are labeled with that permanently. And we must check the stamp of irradiation before infusion of infusion 2. And also in this form, we write pre-transfusion, during transfusion, and post-transfusion vitals, transfusion started time, and transfusion completed. This is ABO incompatibility and management. That is very important. I briefly discussed about ABO mismatch. There are 3 types of.
Yes? Sorry, Gupta needs to mute his or her microphone because it is creating noise.
Yes,
Gupta,
yes.
Gupta, please mute your mic.
Okay. Next is ABO incompatibility and management. That is very important. Sir, continue edited this voice.
Hello,
Okay.
Gupta. Gupta, please mute your mic.
Yeah, so
Mute your mic, please. Your voice is disturbing presentation. Mute your mic, please. Thank you.
Okay. Next is ABO incompatibility and management. I briefly discuss about ABO mismatch. There are three types of ABO incompatibility: major, minor, and bidirectional. The basic concept about these incompatibilities are that in major ABO incompatibility, patient have antibodies in its plasma, whereas in the case of minor ABO incompatibility, donor have antibodies in its plasma, whereas in the case of bidirectional, both patient and donor have antibodies in their plasma. And we should know that in the case of major ABO mismatch, or first choice ABO mismatch, during the early days of transplant, we should stick to patient type of RCC and donor type of FFPs and platelets. But later, when the transformation to donor type blood group has been achieved, then we can switch to donor type blood group of RCC and same as FFPs and platelets. While in the case of minor ABO mismatch, during the early days of transplant, the RCC should be of that of donor type, and FFPs and platelets are of patient type. And later we can switch to donor type of RCC and same as FFPs and platelets. While in the case of bidirectional, where both A and B has antibodies in their plasma, the only blood group O is our first choice for RCC, while in the case of FFPs and platelets, we can transfuse any type. So next is the management of the ABO incompatibility. In the case of major ABO incompatibility, this flowchart basically shows that how should we deal with ABO incompatibility in the case of major recipient IHA titers. Patient IHA titers are done. If it is more than or equal to 1:ratio 6:4, then irradiated donor type of blood is transfused during busulfentine conditioning. And if if the patient tolerated 40 to 60 ml of donor type blood without any major reaction, then no action needed. But when not tolerated and the IHA titer is greater than or equal to 1:ratio 6:4, then bone marrow needs to be red cell separated before infusion. While in the case of minor ABO mismatch, donor IHA titers are done. If it is more than or equal to 1:ratio 256, then 3 to 4 months before transplant, we start donor type of blood. If 3 to 4 months of donor type of blood transfused in a transfusion dependent condition, then no action needed. But if a patient had donor type blood couldn't given, then remove plasma from bone marrow before infusion. Whereas in the case of bidirectional, both donor and recipient IHA titers are done and refers to minor and major ABO incompatibility algorithm. And major ABO incompatibility may cause significant reaction for recipient IHA titer greater than 1:ratio 6:4 and for red cell volume greater than 50 ml. 1 ml per kg in children.
बूझ के बता दे तो हाँ ये कले आंसर दे ना हाँ तो
Tina, please mute your microphone.
तो ना अस्तिन तो मुन्ना रहता है
So Bina.
Bina, switch off your microphone, please. Okay, thank you.
Okay, donor type blood in small incremental liquids of 5 ml to 60 ml starting the day of after ATG infusion are completed and can be safely used checking IHA titers after the last administration if there are any concern regarding reactions. If patient is known to have major ABO incompatibility, donor type of uncrossed blood need to be ordered. A single bag of allocated into 4 to 5 PADI units, irradiated and kept ready before the start of busulfan in the conditioning regimen. We start with 5 ml of day 1 of busulfan, then gradually increase it to 10 to 15 ml of day 2, and then 40 to 60 ml on day 3 and 4 of busulfan, monitoring for any severe reaction. During busulfan days, these are the days because the patient received 2 immunosuppressant and patient immunity is suppressed, and he or she doesn't react to ABU mismatch or CC transfusion. Therefore, we sensitize the patient in these days, but we should conscious about transfusion and also connect cardiac monitor. Some of hemoglobinuria, mild triggers are common during donor type infusion and should be watched out for. The basic concept of this sensitization is to consume any anti-donor type of antibodies which are present in patient plasma. Generally, this procedure brings down the IgG titers in the acceptable range, avoid any need for manipulation on the day of marrow infusion. But if there is any doubt regarding the effectiveness of the procedure, a further allocate can be given on the rest day just before transplant. But if patient is able to tolerate 60 ml of blood, then there is no need to retesting of IgG titers, and there is no need to separate the red blood cells from the bone marrow. So now moving briefly about type of blood transfusion reaction and what are our responsibilities in the management of transfusion reaction. Transfusion reaction may be seen in up to 1% of the transfusion, although despite all these above mentioned practices, transfusion reaction may occur. There are 2 types of reactions, acute and delayed. Acute reactions within 24 hours or during transfusion, and delayed after 24 hours. Acute immune-mediated reactions are hemolytic reaction, febrile non-hemolytic, urticaria, and anaphylactic. Delayed immune are hemolytic reaction, post-transfusion purpura, and GVHT. Acute non-immune are septic, circulatory overload, hyperkalemia, hypocalcemia, and delayed non-immune are infection and iron overload. If any reaction noted, record the following information on the patient notes: type of transfusion reaction, time lapse between start of transfusion and when reaction occurred, and also volume, type, bag number of blood products transfused. Our nursing management or nursing responsibilities: stop the transfusion immediately, notify the physician, connect the IV line with normal saline, observe the sign and symptom, and monitor vital sign till they become stable, and also get ready the emergency drugs such as vasopressor, antihistamine, steroids, and fluids, etc. Prepare for CPR, obtain a urine specimen and send to the laboratory, save the blood container and tubing for return to the bank, and document the reactions and measures carried out. Next is acute hemolytic reaction. Acute hemolytic reaction develops during the first 5 to 15 minutes. And in these reactions, basically, RBCs are hemolyzed with the release of hemoglobin, and it is characterized by fever, chills, dyspnea, chest pain, nausea, vomiting, also tachycardia, tachypnea, hemoglobinuria, and hypotension followed by shock, oliguria, then anuria followed by renal failure. And nursing management of acute hemolytic reactions: closely observe the patient for first 10 minutes. The rate of flow should be minimal initially, and discontinue the transfusion immediately if reaction occurred. And also notify the physician, inform the laboratory to do cross-matching and grouping of the blood, and large quantities of fluid is to be given to promote diuresis and counteract shock. Monitor vital sign every 15 minutes to assess shock and collapse, and also record intake output to assess the kidney function, and also give oxygen inhalation to relieve dyspnea. and immediately take post-transfusion blood sample. One is clotted and one is anticoagulated from vein opposite the transfusion site. Repeat ABO and RHD group, repeat cross-match, full blood count, direct antiglobulin test, and urea and creatinine. And we should return the following to the blood bank transfusion set, which containing blood cells and plasma residue, and also completed transfusion reaction report form. Febrile reaction. Febrile reaction usually develops immediately or within 6 hours of infusion, and it is also characterized by fever, headache, backache, delirium, and shock and renal failure. And we can prevent from febrile reactions when we use proper screening of donor, use of disposable and pyrogen-free sterile syringes, and tubing for collecting and transfusing the blood, and also proper technique for storing the blood. Allergic reaction. It develops or within 1 hour of transfusion, and allergic reaction are the result of sensitivity of individuals to the plasma protein in the transfused blood, and it is also characterized by itching, rashes, and bronchial spasm in severe cases. Treatment of allergic reaction is the injection of antihistamine and corticosteroid, and also washed RBCs are used for the rare patients who have had moderate to severe allergy. Next is anaphylactic reaction. Anaphylactic reaction, extremely rare but life-threatening, and develops immediately after transfusion of few drops of blood, and it is caused by idiosyncratic reaction in patient with IgA deficiency, and it is characterized with dyspnea, cyanosis, tachypnea, tachycardia, hypotension, and then collapse. Our nursing responsibilities: immediately transfusion is stopped, and inform to physician, and resuscitative measures are started, and also the monitor vital sign every 15 minutes until patient recover. Next is delayed hemolytic transfusion reaction. Delayed hemolytic transfusion reaction is defined as the detection of new red cells antibodies after 24 hours of transfusion. It is usually appear 5 to 10 days after transfusion, and it may be characterized by fever, flu-like symptoms, jaundice, anemia, and in the investigation, DAT is positive, LDH is also increased, total bilirubin is also increased, haptoglobulin reduced, and antibody screening. Next is transfusion-associated GVHD. Transfusion-associated GVHD is defined as a delayed immune transfusion reaction due to an immunological attack by viable donor lymphocyte. And transfusion-associated GVHD most occur in patient immunodeficient recipient of bone marrow transplant and immunocompetent patient transfused with blood from individual with whom they have compatible HLA tissue type, usually blood relative, particularly first degree. And as I mentioned before, that it occurs 10 to 12 days after transfusion, and it may fever, diarrhea, elevated liver enzyme. Also, pancytopenia occur between 3 and 30 days post transfusion of a non-irradiated cellular blood components. Unlike the hematopoietic progenitor transplant, transfusion-associated GVHD leads to profound marrow aplasia with a mortality rate greater than 90%, and death occurs 1 to 3 weeks after first symptom appear. Treatment is supportive, not curative. Next is circulatory overload. Giving whole blood to patient instead of RCCs, as in anemic patient, cause circulatory overload. Condition of heart failure may also cause the circulatory overload with blood transfusion. And prevention of circulatory overload, used pack RBCs instead of whole blood, and also administer diuretics prior to blood transfusion, and also transfuse the blood at a slow rate. Check the patient pulse every 15 minutes. Check the patient neck vein for fullness. Observe the CVP line, and also observe for a sign of respiratory distress. Give minimum quantity of blood at a time. And if the reaction occurs, stop the transfusion and inform to the patient if patient develops the sign and symptom of circulatory overload. Next is hyperkalemia. Basically, stored blood may cause hyperkalemia. Blood that is 1 day old has plasma potassium content approximately 7 MEq per liter, and 21 days old blood contain about 23 MEq per liter potassium. Hypocalcemia usually develops due to citrate toxicity because of massive transfusion citrate in the blood combined with ionized calcium, and tetany may result. The treatment of hypocalcemia is the administration of calcium gluconate to prevent or eliminate the toxic effect by neutralizing the acidosis. These are all references of my presentation. Thank you all for listening. Any questions?
Thank you very much, Samia. There was a lot of work. You presented very well.
Thank you, sir.
Thank you. Yeah, any questions? Yes.
I think you did a very, very good job, Samia. You have been working very hard, very, very nice, your presentation, very nice. I have only one question for you. Why we need to irradiate